we have Dr. Dahl. He is a pediatric otolaryngologist at Seattle Children's and an assistant professor in the Department of Oto, Head and Neck Surgery at the University of Washington. Dr. Dahl completed residency training in Oto Head and Neck Surgery at the University of North Carolina, Chapel Hill, and a fellowship in pediatric Oto Head and Neck Surgery at Seattle Children's. Prior to joining the faculty at the UW, Dr. Dahl spent 3 years on the faculty of the Indiana University School of Medicine and served as the surgical director of the aerodigestive program at Riley Hospital for Children. Dr. Dahl has a significant interest in basic and clinical scientific research related to vascular anomalies, tracheal malformations, airway management in patients with complex craniofacial disorders, as well as patient quality and safety.
Yeah, thank you so much for the introduction and for the opportunity to present today. My talk is You Can't Trust a Toddler, a contemporary review of aerodigestive foreign bodies. This is a topic near and dear to my heart as a pediatric otolaryngologist, and I hope you guys will find this interesting. I do not have any disclosures. Our learning objectives are really to learn how we approach children with aerodigestive foreign bodies, what our diagnostic workup is, how to differentiate between esophageal and airway foreign bodies with regards to both diagnosis, treatment, and potential complications. And another important point for this audience is to recognize and be able to triage patients with button battery ingestions, because that is a life-threatening emergency. So just by way of background, compared to adults, pediatric airways are small. I know that's not surprising, but when you look at this and you look at the physics of it, so a normal adult airway is 12 millimeters, a normal pediatric, so a child airway is about 4 millimeters. If you narrow that child's airway by 1 millimeter, you're going to drop the airway cross-section by 75%, increase the resistance through which they have to breathe by 16-fold. This same 1 millimeter narrowing in an adult drops the airway cross-section only by 30% and increase the resistance by 2-fold. So you can see the size of the pediatric airway is really critical in these cases, because a small change in the airway diameter can significantly increase the work a child has to do to breathe. So foreign bodies in the airway, this is a picture of Dr. Chevalier Jackson, who taught at my medical school, not when I was there, I'm not quite that old, but his instruments were on display there. And kids die from this. So airway foreign bodies, there's roughly 1,000 deaths per year in the United States. These patients tend to be male toddlers, let's just be honest. 70% male, average age 32 months. And organic foreign bodies such as nuts make up over half of the airway foreign bodies. And this is something we see routinely on call. And they can get dicey real fast. So a typical history for an airway foreign body is a choking spell while eating, followed by altered respirations, although this isn't always the case. We do worry about foreign body ingestion or aspiration if the young child has an unexpected loss of consciousness. That would be weird for a young, healthy kid. If you're encountering this history, it's always great to ask the family, did you have what they were eating or playing with? Because sometimes we can compare an x-ray of that suspected foreign body to the child to see if the foreign body is actually radiopaque or will be seen on an x-ray. And then it's always helpful to know the last time the patient ate or drank, because the treatment for any of these foreign bodies is operative. If they're not NPO appropriately for surgery, we don't wait for airway foreign bodies. It just increases the risk of aspiration. For esophageal foreign bodies, unless it's a button battery, the patient's really struggling, we often will wait for them to be appropriately NPO for a general anesthetic. So in terms of the physiology of airway foreign bodies, there's a couple of different things that can happen. So one, if you have a smaller foreign body that you see in A right here, there's this bypass valve phenomena where you can breathe around it. The airway's still obstructed, but the child can breathe and exchange gases, more importantly. This check valve phenomenon, when you breathe in, you can breathe in, but the pressure changes as you go to exhale, and you can't exhale. So while you can oxygenate, the patients develop elevated CO2 levels. And then the last one, mechanism D here, is the dreaded stop valve, where you can't breathe in or out. And I'd be honest with you, most of the deaths from these airway foreign bodies occur in situation D, and a lot of them actually occur before the patients even reach the hospital. So what do you do if you suspect an airway foreign body? Well, you do anything you normally would do. So you're going to want to take a history, you want to do an exam, and you're going to look at appropriate diagnostic testing. So the history is really, in my opinion, probably the most important part of the entire evaluation. And what you're trying to gain from all three of these diagnostic modalities is the risk benefit there to take this patient to the operating room for general anesthesia and a rigid bronchoscopy to look for a foreign body. So obviously, did the parents see the child aspirate? What time was it? What was in their mouth? What did they look like? What happened afterwards? Are they coughing? Were they cyanotic? Did they pass out? And this has actually pretty good sensitivity, but not great specificity. When you look at the child in the exam room, what do they look like? Are they a happy little kid who's playing and doesn't seem bothered by it? Or are they, drooling, miserable, inconsolable? Do they have stridor? What are their breath sounds like? Are there decreased breath sounds on one side? And then you can consider imaging. X-rays are not great in terms of determining whether or not there's a foreign body. If there's an obvious X-ray change, then that can be pretty diagnostic. But if there's no change, you can't rule out a foreign body. Some centers are moving towards a CT scan to diagnose a foreign body. We're not doing that because it's a dose of radiation, and then you're putting a child with a potential airway foreign body in radiology alone, which is not necessarily the safest environment for them to be on. But when you look at all these different factors based on literature, which is not great studies, but it's what we have, the history plus physical exam plus chest x-ray findings, maybe gives you about a 50-50 shot at determining whether or not there's a foreign body. So it's one of those things that we have a pretty low threshold to go to the operating room, because the diagnostic laryngoscopy and bronchoscopy there really is the gold standard for ruling in or ruling out an airway foreign body. So the imaging, as you can see, there's a whole host of different X-ray views that you could obtain. Again, sensitivity and specificity are not awesome, and we're not using any of the other options that are listed on the slide for a number of different reasons. So treatment is rigid endoscopy with foreign body removal. It's both diagnostic and therapeutic. Here's a child who had aspirated this giant evergreen leaf that I removed as a fellow. You can see it in the airway and how long it was based on the endotracheal tube, just for size. It was about 3 centimeters. There's a whole host of other potential treatment options, some of which don't work great, and the other ones are really invasive, such as tracheotomy, thoracotomy, and ECMO. With our current suite of instruments and techniques, it's pretty rare for us to have to consider any of these other options. These are what the instruments look like for the procedure. So we have our Parsons laryngoscope here. We have our high definition camera and rigid telescope, which is actually, these are glass scopes encased in a stainless steel sheath. We also have a whole host of laryngeal instruments available in case they are needed. This is, again, a standard for any of our airway evaluations. The foreign body equipment looks like the craziest erector set you could have ever had as a child. During some of our teaching sessions with our residents, we actually time to see who can do this the fastest, because these pieces are not intuitive to put together. But this is what the bronchoscope sheets look like. They then have these various adapters and pieces that will go on to the bronchoscope, and then the telescope will go through the bronchoscope. And then we have various grasper instruments that we can use also through the bronchoscope. The key thing about the bronchoscope is this plastic tube here is an adapter that allows us to connect the bronchoscope here to the anesthesia machine, so we can ventilate and oxygenate these patients with the bronchoscope in place. There's always a leak around it. It's not as good as having an endotracheal tube in place, but it does allow us to do the procedure with a native airway while still oxygenating and ventilating the best we can. Just to point out here, this is a close-up view of a bronchoscope versus an esophagoscope. The rigid ones, the bronchoscopes, are ventilating, so they do have side ports that allow the anesthesia gases and more importantly, oxygen and carbon dioxide to go in and out through the bronchoscope. An esophagoscope obviously doesn't need those because it's going in the esophagus. And so that's how you tell the difference. Here's an example of the forceps that we then deploy through the bronchoscope. So essentially during the procedure, we get a view of the voice box through the mouth. With the laryngoscope, we put the bronchoscope into the airway. We then connect to the anesthesia circuit, identify the foreign body, and then use these, what we call optical forceps. So the telescope goes into the forcep, and they have these little graspers on the end, depending on the foreign body. And that's how we directly visualize the foreign bodies, grasp them, and then remove them through the bronchoscope. So let's take a look at an airway foreign body. This is one I did as a fellow. So this was at Seattle Children's, obviously. 4-year-old playing with Legos, and then did not do well. Very acutely decompensated. The patient was brought via EMS. She was not breathing well when we saw her in the ER. She was emergently brought to the operating room, and this is a view of her voice box. You can see her vocal cords here. Those are the white things on the side. And then right here is the Lego chalice that is now bouncing between her carina and her voice box. So this is the optical forcep. This is me trying to grab the Lego chalice. And if you notice, there's a hole in the middle of this chalice. That's probably what saved her life, because she could breathe through it, not just around it. And then I drop it, regain it. And this is the most dangerous part of the procedure, because these foreign bodies can get lost between the trachea and between coming out of the trachea and going through the vocal cords, because that's the narrowest part of the airway. So you have to be cognizant of that when you're removing the foreign bodies. Whoops. So here's one that's been there a little bit longer, going back to our organic foreign bodies. This is a 9-year-old with a week of wheezing. And he was actually doing pretty well. He had seen a bunch of different people in the medical profession. He'd been given antibiotics and nebulizers and all kinds of stuff. So when we took him to the operating room, he had one of these nuts in his trachea. Actually, it's in his mainstem bronchus. And you can see the organic foreign bodies are very different, especially one that have been in there for a while, than the plastic inert foreign bodies. They get soft, they break up, they're kind of mushy. What you're looking at here is the distal trachea. The right mainstem bronchus is here. The left mainstem bronchus is here. You can see we're trying to grab the pistachio and bring it into the bronchoscope, because that's the safest way to remove it. Oh, and we dropped it, which happens not frequently. And then it goes in the other side. So now we have to reposition the bronchoscope, try to grab it again, and we miss it. And then we try to grab it yet again. And this is all done, again, while the patient's under general anesthesia, but breathing on their own. So it's really remarkable. Our anesthesia colleagues can keep these kids under anesthesia, breathing on their own, so they can protect their airway and still move oxygen and carbon dioxide, but allow me to put this rigid tube in their airway and yank out things like pistachios. And then, whoops. So this is probably the scariest one. This is a chronic airway foreign body. This was at my previous institution, one of our NICU nursing colleagues, another pistachio here, younger child, 18-month-old, again, was seen by tons of people. And finally, he was pretty symptomatic. Mom was frustrated, just called my clinic from work. And so we popped by the NICU and saw her and brought him to the OR the next day. And this is what it looks like when you've had pistachio in there for over a month. So this is just the right main stem bronchus. And you can just see how unbelievably inflamed and soft and even mushier. And this is all granulation tissue around there. It's really, really stuck. So this was about an hour in, and then we saw that right there. And what you're looking at is a hole in the bronchus, and you're staring at by suction in the chest, and that's lung you're looking at. So we did understand that. Got a chest tube in, and then there was more pistachio distal to the injury that we had to use even smaller instruments through the bronchoscope to remove. So this whole procedure, we were in there for a good 3 hours. And you can see on the way out there's the hole in the bronchus intermedius, and that's the lung. Not what you want to see endoscopically. But this patient actually did really well with some conservative management. And then there is the area on repeat bronchoscopy a couple of weeks afterwards, and it healed up very well. But this child could have easily died as part of this removal. He was really lucky that we identified the injury so quickly and were able to act on it. So the point of showing these different videos is to just give you the perspective of just how dangerous these things can be, regardless of how long they've been in place. So now I'm going to pivot and talk about esophageal foreign bodies, which are actually way more common than airway foreign bodies. And most of them, actually, the kids swallow and they go into the stomach and then they poop them out and nobody has to do anything about it. But they can also be problematic and can be, some of the estimates right now are 1,500 deaths annually. And a lot of those deaths are due to button battery ingestions, which we'll also touch on. So esophageal foreign bodies, there's less literature on this than airway foreign bodies, but it's really the same thing, your history, your physical, and radiology. The history and physical on this are probably less sensitive, but radiology, especially for something metallic like a coin or a button battery, usually is diagnostic. A button battery is considered an emergency, and those patients, regardless of what's going on, will be brought to the emergency room brought to the operating room in an emergent manner to remove the foreign body because time is of the essence. So there's a lot of public health and education going on regarding button battery ingestions right now. More than 2,500 occur in the year or per year in the U.S. We just had a kid actually 2 nights ago ingested a button battery and now has a very large hole in his esophagus, which is not an easy thing to fix. So I can't stress how much, if you have any concern about a button battery, that's an absolute medical emergency and must be escalated as such. So why is it such a big deal? Well, the batteries still have charge. Even a battery that can no longer charge your car key fob or any toy still has current left in it. And what happens is when it gets in the esophagus is a pretty tight space, and the esophagus will collapse on it. And then that'll actually cause the battery to release its current. And what you do is you get hydroxide ions at the battery's negative pole, which causes a basic injury, an alkaline injury. And then there's also this physical pressure on the foreign body distending the esophagus. This is, again, some demographic information. Tends to be male toddlers. Nobody's going to be surprised by that. And they can be put places other than the mouth too. Ear canal, nose, but the most common thing is if they swallow them. And as you can see, this is a little bit of a confusing graph, but on the left here, there's ingestions per million population, moderate, major, fatal outcomes per million population over the years of 85 to 2017. And you can see the trends are increasing for all of these as button batteries have become more prominent for use in electronic products. It's a great technology, but now there's a move front to try to phase these things out just because of how dangerous they can be if they're ingested. So if you're concerned about an esophageal button battery ingestion, regardless of where your site of practice is, you want to send those patients to the closest emergency room immediately. Do not induce vomiting. If we have a call from a parent at home, say, hey, my kid just swallowed a button battery. If the kid is over 12 months of age and they have honey at home and the kid can swallow, they could give the patient 2 teaspoons of honey every 10 minutes for up to 6 doses. And there's one study that sort of suggests that this can kind of coat the esophagus and protect it to somewhat from the alkaline injury that the battery can create. Now, if the kid is under 12 months with honey, there's the risk of botulism, so we don't recommend that. But other than the honey, don't give the child anything to eat or drink until well after they've been evaluated in the emergency room. If the patient is in the emergency room and it's taking a while to mobilize an operating room, they can be given Carafate, which does the same thing theoretically as honey, but this is nothing that should be given. You shouldn't delay the patient's surgical care to administer Carafate. The main thing is you want to mobilize the operative team. When these happen here, usually we know about it in advance. Our communication center will contact the emergency department physicians and nurses, who will then contact the surgical services, the charge nurse in the operating room, and we will have a team ready to go. So when that patient hits the emergency room, like, they're in the operating room in well under an hour. And just here's our institutional protocol for this. So either they go to the outside or they show up in our ER. And as soon as they're concerned for a battery ingestion is flagged, the guidelines are initiated. The communication center, again, will reach out to the appropriate surgical or procedural teams. And then we are ready to take that patient to the operating room as soon as possible. This is the study that provides data supporting the Carafate, the honey administration. Essentially, what they did is they took, it's going to sound weird, but they used pig models and took their esophagus and put batteries in there and then coated them with either honey or Carafate to see if it decreased the burn and the tissue pH. And it sort of did. It's something that's in our algorithm, but it's not, again, not something that should delay the child's definitive care, which is the operating room. So this is always one of my favorite slides to show. this is what you can see if you have a button battery. And it's got this very classic, everybody who's seen a button battery knows that there's a little step off there, and the button battery will have this halo sign. If anything looks like this halo sign that we see in the esophagus, and you sort of see it on the lateral too, those patients go into the operating room emergently for esophageal foreign body removal. So here's a video of one of our cases. My colleague, Dr. Bonilla, is an esophageal foreign body magnet, and she also tends to see all of the button batteries on call. So the residents love to take call with her. But this is the X-ray, and you can see that halo sign. And that's a great view, lateral view of the halo sign. The kid looked good in the emergency department, but this is a radiographic finding that we take very seriously. So there's the voice box, and there's the surgical team, Dr. Bonilla, looking in the airway, and that's all normal looking airway. The reason why you would look in the airway is to make sure that the button battery hasn't eroded into the trachea either. And then there's some granulation tissue in the esophagus, so this has been there a while. And it's kind of funky looking. But then, just gonna grab it. And I'll just note, this all looks pretty healthy around here. And then they're gonna come out and look, a penny and a dime. So the halo sign is not 100% sensitive for the button batteries, but if we see something like that, and I've seen this a few times over the course of my career, different coins stacked in each other looking like a button battery, they're still going emergently to get those removed because we really can't differentiate between the two scenarios. This, on the other hand, is really a button battery. Again, Dr. Bonilla, I appreciate her sharing her videos and her expertise with me for this talk. Here's the X-ray. Again, pretty good for the halo sign. Or whoops, I'm sorry. This is the last one, I apologize. So this kid is not doing great. Vomiting. Parents found a remote that was missing a button battery, and you can see the halo sign here. Here it is on the AP. This is what an esophagus looks like when you've had the alkaline injury from a button battery. And just to remind you, the esophagus is just a fibromuscular tube. There's not a lot of structure around it. And this is what it looks like when the button battery's been in there for 12 hours. So you can see right here is healthy esophagus, but around here is really not healthy esophagus. And it took them a lot to get this button battery out of the esophagus, because once the reaction occurs, the tissue around it starts to hydrolyze, and it just all kind of forms this reactive, almost scar or capsule between the esophageal tissue and the button battery. And it's, I mean, it's stuck. And so it's tough because you got to try to get it out there without creating a huge hole in the esophagus. But the longer it stays there, the more it's going to injure the esophagus. In this particular procedure, it took them over an hour to get the button battery out of the esophagus safely. And then this is what the esophagus looks like on repeat esophagoscopy. You can see all that just charred, destroyed tissue. This kid actually did pretty well, but that's not always the case because of the sequelae, potential sequela from the button battery. So all these kids go to the intensive care unit. They don't get to eat or drink. Usually we get an esophagogram a couple days afterwards. But we really worry about all these potential complications, esophageal perforation, mediastinitis, the recurrent laryngeal nerve, which controls the vocal cords, runs right by the esophagus, so you can get vocal cord paralysis. It can erode into the prevertebral fascia and the spine. And then there are reports of these eroding into the great vessels and causing a terminal bleed. The scarring in the esophagus can cause long-term strictures. So it's just really, this is bad news when it happens. And then here's just an example of one in the ear, also from Dr. Bonilla. This is the ear canal. The eardrum is right here and right here. And this was only in for an hour or so. But you can just see that the just absolute damage that these button batteries can have on the tissues that they come in contact with. So how do we really address this? Well, airway foreign and esophageal foreign bodies is prevention. So there are some legislative statutes in place to try to educate parents about choking hazards and limitations on the size of certain toy diameters. But a lot of this is when you're seeing parents in your practice, just really good supervising skills, making sure children are eating age-appropriate food, they're supervised. And the other thing is, if you do have button batteries or other hazardous things in your home, that they're stored away from where young children can get to them, just to try to reduce this risk. This is my daughter eating edamame, but she was 8 at the time, which I think is reasonable. And finally, I'd just like to conclude, if you have any questions about these or any other otolaryngology issues, we have a big group, a lot of expertise, a lot of experience in this group, and we're always happy to interact with our colleagues and try to help our patients. This is a picture on my chief, Dr. C, her wall. We've got 3 of these from the various foreign body removals we've done over time. And so I'd just like to point out, this is the Lego chalice that was in the acute airway foreign body video. So each of these has got a story behind it. And, these patients are lucky that we were able to remove them, most of them without any complications. And I would be happy to take questions from anybody on this or any other otolaryngology topic that may be on the front of your mind.
Thank you so much for that talk. We have a group chat going on, and we're all saying we're rooting for those objects to be retrieved whenever they were dropped. So I'm glad that they were retrievable.
Yeah, me too.
So there is one question right now. Do you have thoughts on the dechoker device? I'm not sure what that device is. Are you familiar with that device? Dechoker.
I'm not familiar with that device. The Heimlich maneuver is something to consider doing appropriately, but we don't recommend any other instrumentation. I've actually seen pretty bad outcomes from parents who've tried to finger sweep when they're concerned about their child choking, that caused a couple pretty nasty injuries. And so Heimlich, and then just getting the child to the appropriate level of medical support is what we recommend, even if that means engaging 911 to get them to the closest emergency department.
Mm-hmm. And along using the Heimlich, is your recommendation that if you are suspecting that the child is choking, but they're not, showing like active signs of like respiratory distress, they're not severe respiratory distress or are coughing, and you're suspecting that they're choking, or they might have choked or swallowed something, you would still recommend doing the Heimlich?
No, I would recommend in that scenario going to the operating room. The Heimlich would only be if you were really worried about like an acute like
Mhm.
obstruction that's not going to wait for EMS. If the patient is stable, I would get them to the closest emergency department.
Mhm. Okay. And then I'm not seeing a whole lot of questions in Slido, but I have some questions of my own. With the battery ingestion, what is sort of the long-term damage that's done to that airway? Like, what happens after that? Like once they're recovered from the ICU?
It really depends on the patient. So the case that I presented, the esophageal button battery, that kid was lucky and did really good. She's had follow-up. She hasn't had any esophageal strictures. She's on a regular diet. But the kid with the esophageal button battery that came in after her had a
Mhm.
really giant hole in the esophagus, got mediastinitis, was really sick, critical condition for a number of days. And then eventually what we had to do was something called a slide tracheoplasty, where she had a median
Mm.
sternotomy. We basically segmented the trachea, took the bad part out, sewed it back together, and did the same thing for the esophagus, and then actually rotated some additional tissue between the trachea and the esophagus um, to close the hole between the trachea, the esophagus, and the mediastinum. And she ended up doing okay, was probably in the hospital for 3 months. And then again, there's a certain percentage of patients who just have a catastrophic injury and end up passing because of it.
Mhm. Yeah, thank you. That's really scary. It just kind of reminded me, I actually let my son, my 3.5-year-old, eat pistachios while I was on a meeting yesterday with headphones on. And I'm rethinking that decision now, after the videos that you showed me, even though he knows how to chew a nut. So um, uh, a good reminder to watch out for those toddlers, especially those little guys. Uh,
Yep.
well, I don't see any other questions, but just, oh, sorry, one question. Um, let me. Are you seeing many magnet ingestions and suggestions for how to know when that is an emergency if unwitnessed?
Yeah, we do see some magnet ingestions. Um, a single magnet isn't super concerning, and they'll just poop it
Mhm.
out. But if there's two magnets, that puts it in a very acute situation, because if the magnets transit through the GI system, if one is a little more proximal or distal, the magnets can come together and then magnetize, and what that can do is cause ischemic bowel, which is a general surgical emergency. And they should be seen on X-ray. But that's something my GI and general surgery colleagues do see, and it's definitely an emergency, and it's very concerning.
Mhm. Okay. Um, and what types of incidents are prevalent among elementary school kids in school?
A lot of these we see are home because the kids tend to be just a little bit younger, but there's definitely some, playground dares and things like that. Those tend to be some of the more creative foreign bodies. The larger ones, which are some of the more dangerous ones, some of the hair clips and the pins. And the other thing we see in school age children is even though they know they shouldn't, they'll put things in their mouth, and all of a sudden somebody will come up and slap them in the back, and then all of a sudden they swallow it. I just took a Canadian flag pin, like a big one, out of a 7-year-old's esophagus who was doing that. Um, so the main thing is you just tell the parents, kids do these things. This isn't a malicious thing. No harm, no fall. Don't do it again.
Yeah. And then do the children have a sensation that there's a foreign body, especially if the one chronic one that you showed, or if the pistachio staying in there for a while? Do they feel
Yes.
something there?
Oh yeah, absolutely.
Uh-huh.
And that's a challenge for all of us who are in pediatric healthcare, right? The younger children don't have a great ability to fully verbalize what they're feeling or how they're feeling. And so we have to have good examination skills. We have to understand the demographics of these conditions in our population. And, we have to listen to the parents. And that one example that you brought up, that again, the mom is a NICU nurse and had been, her current concerns had been, what's the right word? Not fully accepted by the various providers she had seen. And that's why she just got fed up. And again, she was at work and paged me and ran the situation by me. I was like, we should take a look at his airway.
Mm-hmm.
Yeah, because she had been dismissed so many times. So I think that's a key to this. Listen to your parents. It's
Yeah.
an opportunity for shared decision making, right? The risk of a bronch isn't that much, but a missed foreign body is. So this is an opportunity to engage parents, share decision making, in these gray area situations.
Yeah. And what are some descriptions or descriptor words would a child use to describe if they feel like something is stuck in there? What have you heard them use?
They've got a tickle, they've got a chronic cough, they've got an itch, they've got a scratch. For the esophageal ones, for the airway ones, it's more honestly physical things. There's chronic coughing, maybe some dyspnea on exertion, some wheezing, decreased breath sounds on one side. They can have fevers. Those kids tend to not feel well too, just globally, kind of more lethargic, irritable, things like that.
Mm-hmm. Okay. And then last question, with the popularity of baby-led weaning practices, are you seeing issues related to this?
Hmm.
Mm,
Not that I'm aware of.
mm,
Not that I'm aware
mhm.
of.
Okay. All right. Just a lot of general feedback about how great the presentation was. And I don't see any more questions. Um, and so thank you so much for speaking to our group of nurses today. Um, very, very interesting talk.
My pleasure. Thanks for inviting me. Really appreciate it.
Yeah.
Have a good day.